Welcome to the deep dive. If you're listening to this right now, chances are you're a nursing student deep in the trenches of med-surg.
The infamous medical surgical rotation.
Right, and you are probably staring down this massive stack of reading, and you're trying to figure out how to keep all these intricate bodily systems straight in your head before your next clinical rotation.
Which is completely normal, by the way.
Yeah, exactly. Well, you're exactly where you need to be. Today, our mission is to tackle a really dense, highly testable, and absolutely critical piece of your curriculum. We are looking at Week 8, Chapter 49.
Management of patients with urinary disorders.
That's the one. And we're going to move way beyond just the rote memorization of those textbook tables.
Because the goal here isn't just to help you pass your next exam. A deeper understanding will organically do that anyway.
Right. Our true goal is to unpack the why and the how of genitourinary care. We want to take this heavy pathophysiology and translate it directly into real-world bedside nursing practice.
And that translation from textbook to the bedside, that's where the real nursing actually happens. While the genitourinary, or GU system, might not always get the same dramatic, fast-paced attention in nursing school as, say, the cardiovascular system.
Or neuro. Everyone loves neuro.
Exactly. But it is absolutely foundational to your patient's survival. If we connect this to the bigger picture, the urinary system is far more than just a passive plumbing network for waste removal.
It's not just pipes.
Far from it. It's a highly sophisticated, elegantly coordinated neurologic, chemical, and mechanical system. It balances electrolytes, manages fluid volume, regulates blood pressure, and maintains an incredibly strict sterile environment in the upper tract.
And when that system fails, whether that failure comes from a microscopic infection or a physical obstruction.
Or even a severed neurologic connection.
Right. The consequences just cascade through the body so rapidly. A simple localized issue in the bladder can spiral into massive life-threatening complications like urosepsis or acute renal failure in a matter of hours.
It happens incredibly fast on the floor.
Okay, let's unpack this because the sheer volume of urinary issues you are going to see is staggering. Urinary disorders account for nearly 25% of all infections in the human body.
That's 1 in 4.
1 in 4. They are responsible for countless hospital admissions, and I guarantee they're going to show up on every single clinical rotation you do.
Absolutely. Mastering this material is going to directly impact your daily practice, whether your dreams to work in a high-acuity ICU, oncology, or out in community health.
You just cannot escape the GU system. So as a nursing student, where do we even begin to look for the cracks in the foundation?
We begin where the system is most vulnerable to the outside world. To really understand the pathology, we first have to establish the baseline anatomy and how the body naturally defends itself. Clinically, we divide the system into 2 distinct zones.
The upper and the lower.
Correct. You have the lower urinary tract, which includes the bladder, the prostate gland in men, and the urethra. Infections down here cause things like cystitis, prostatitis, and urethritis.
And then you have the upper urinary tract.
Yes, the ureters and the kidneys themselves. An infection that makes it all the way up there is called pyelonephritis, and it is a significantly more dangerous clinical scenario. UTIs as a whole are the second most common infection in the human body.
I always hear nurses talking about the sterile versus the clean zones, but for someone just stepping onto the floor for their first clinical, what does that actually mean in practice?
It dictates everything about how you approach catheter care and infection control. The urethra is considered a clean space.
Clean, but not sterile.
Exactly. Because it opens to the outside world, it has normal, naturally occurring flora residing in its lowest portion. But everything above that anatomical boundary,
The bladder, the ureters.
and the delicate filtering units of the kidneys, yes, all of that is strictly 100% sterile. The body works incredibly hard to keep bacteria out of that sterile zone.
And the mechanism for keeping it sterile is actually fascinating. The bladder isn't just a basic muscle, right? It has this highly specialized lining.
It does. It secretes a layer called the glycosaminoglycan, or GAC layer.
The gag layer. It's essentially this hydrophilic protein barrier. I try to picture it kind of like a high-tech, non-stick protective coating on a frying pan.
That's a great analogy.
But instead of repelling eggs, it actively attracts water molecules to form this microscopic, slippery physical barrier that literally stops bacteria from being able to anchor onto the bladder wall.
The non-stick pan analogy is incredibly accurate for visualizing the pathophysiology here. The JAG layer is your patient's invisible, microscopic shield. But what's fascinating here is how easily everyday, seemingly harmless habits can compromise that shield.
Like what? What breaks it down?
Chemical irritants in the diet, for one.
Right.
The research specifically points out that artificial sweeteners, things like aspartame, saccharin, cyclamates, they can actually degrade and impair that JAG layer over time.
Wait, really? So diet soda can wear down the nonstick coating of your bladder?
Yes, it can. The chemical breakdown of those artificial sweeteners alters the environment of the bladder lumen, and that compromises the integrity of those hydrophilic proteins.
So if you're doing an admission assessment on a patient who drinks a massive amount of diet soda and complains of recurrent lower UTIs,
That dietary habit isn't just a trivial lifestyle note. It's a critical, actionable piece of your nursing assessment. You've identified a mechanical vulnerability.
that is a clinical pearl you definitely don't easily forget. Hold the aspartame, save the JAG layer. But even if a patient has a perfectly intact, healthy JAG layer, bacteria still manage to find their way in, usually by ascending from the perineum.
They do, and the text talks a lot about reflux mechanisms being the primary culprit.
And to be clear, we aren't talking about GI acid reflux here. We're talking about urine flowing in the wrong direction. Can we break down the mechanics of urethrovesical reflux versus ureterovesical reflux?
Sure, let's start with the lower of the two, urethrovesical reflux, urethra referring to the urethra and vesicle referring to the bladder.
So this is the backward flow of urine from the urethra back into the bladder.
Exactly. To understand this, visualize the physical pressure dynamics in the abdomen. Imagine your patient is coughing heavily, sneezing, or bearing down forcefully during a bowel movement.
That physical action drastically spikes their intra-abdominal pressure.
And that pressure physically squeezes the bladder, which forces a small amount of urine down into the urethra.
But so far, that just sounds like stress incontinence. Where does the actual infection come from?
The infection comes from the pressure drop. When the patient stops coughing or straining, the intra-abdominal pressure suddenly drops back to normal. The bladder relaxes, and the small amount of urine that was just pushed into the urethra.
It gets sucked right back up into the bladder.
Yes. But the problem is, while it was in the lower urethra, it picked up the normal flora, the bacteria that live down there. It acts like a vacuum, dragging bacteria from the clean zone straight past the gates into the sterile zone.
Wow, so it's essentially pulling the invaders right over the moat. And then there's your ureterovesical reflux, which sounds even more dangerous because it's happening higher up the chain.
Significantly more dangerous. Normally, where the ureters connect to the bladder, there is a brilliant one-way biological valve system.
They don't just plug straight in, do they?
No, they tunnel obliquely through the muscular wall of the bladder at an angle. Because of this angle, when the bladder muscle contracts to void, it physically squeezes that tunnel shut.
Oh, so it clamps down on the ureter, completely preventing urine from shooting back up toward the kidneys during urination.
It's a self-sealing mechanism built right into the muscle movement.
That's brilliant.
But if that valve mechanism is impaired, perhaps due to a congenital defect, extreme bladder pressure from an obstruction or scarring, infected urine from the bladder can flow backward all the way up the ureters and into the renal pelvis.
And that is the exact pathway of how a simple, localized case of cystitis turns into pyelonephritis.
Yes, a severe kidney infection that can permanently destroy renal tissue.
So as a nursing student, what does this actually look like when you're standing at the bedside? Because we all know the textbook symptoms of a UTI.
Burning with urination, extreme urgency, frequency, pelvic pain.
Right. But from what I understand, if you rely on those symptoms alone, you are going to miss a massive number of infections, especially on a geriatric med-surg floor. Why does a UTI look so radically different in a 75-year-old compared to a 25-year-old?
This is perhaps one of the most vital clinical scenarios you will encounter. It comes down to immunosenescence.
The natural aging of the immune system.
Exactly. In a young, healthy adult, the immune system detects the bacteria and immediately launches a massive local inflammatory response in the bladder. That local inflammation is what causes the classic burning, the pain, and the urgency.
But in an older adult, that local immune response is often blunted or delayed.
Right, they simply do not mount the local inflammation required to feel the burning.
So if they don't feel the burning, what's the red flag? How do you catch it before it turns into urosepsis?
Instead of localized pain, the infection often manifests systemically and neurologically. An elderly patient might suddenly become deeply lethargic, complain of vague general malaise, or develop a sudden, unexplained onset of incontinence.
But the absolute hallmark presentation, the one that triggers emergency department visits across the country, is sudden delirium or profound acute confusion.
I cannot stress that enough.
I've heard stories of families bringing in their grandparent, absolutely terrified that they've developed rapidly progressing Alzheimer's overnight, only to find out it's a urinary tract infection. How does a bladder infection cause a brain symptom?
The exact mechanism is a subject of ongoing study, but it involves the systemic release of inflammatory cytokines. These cross the blood-brain barrier, altering neurotransmitter function, and you couple that with the fact that the aging brain is already more vulnerable to metabolic stress.
So the takeaway for you at the bedside is absolute. If you have a previously alert-oriented older adult who is suddenly confused, agitated, or acting completely out of character,
A UTI should be at the very top of your differential suspect list. Do not wait for them to complain of burning.
and there are physiological changes in aging that set them up for this vulnerability, right? It's not just bad luck.
It is deeply rooted in anatomical and hormonal changes. In postmenopausal women, the drastic drop in systemic estrogen fundamentally alters the vaginal and urethral environment.
It changes the urethra-vesical angle.
Yes, and crucially, it alters the local vaginal pH. A higher pH makes the mucosal tissue highly prone to bacterial colonization and adherence.
And what about older men?
In older men, the natural antibacterial activity of their prostatic secretions decreases significantly. Furthermore, they frequently develop benign prostatic hyperplasia, or BPH,
Which mechanically blocks the outflow of urine.
creating a pool of stagnant fluid in the bladder. It's a perfect storm for bacterial overgrowth.
But as bad as community-acquired UTIs are, the real monster we face inside the hospital, the one that nursing students are drilled on constantly, is the CAUTI.
The catheter-associated urinary tract infection. This raises an important question for every single nurse to ask themselves at the start of every shift as they review their patients' lines and drains. How much damage are we inadvertently doing with our routine, well-intentioned medical interventions?
The statistics regarding COUDs are incredibly sobering. 50% of all hospital-acquired infections are UTIs, and the vast majority of those are directly linked to indwelling catheters.
It makes physical sense. When you place a Foley catheter, you are literally providing a direct, physical plastic highway for bacteria.
You're bypassing the urethral sphincter, bypassing the JAG layer, and marching the bacteria straight up into the sterile bladder.
And the clock starts ticking the very second that catheter is inserted. The clinical texts are very clear on this. The risk of a urinary tract infection increases by 3 to 7% for every single day a catheter remains in place.
Let's do that math for a second because it's terrifying. If a patient is admitted to the ICU and has a Foley catheter in for 10 days, their risk of developing a COUTI could be up to 70% higher just from the presence of the tube.
This is exactly why the Centers for Medicare and Medicaid Services, CMS, stepped in and classified the CAUTI as a never event.
They basically told hospital administrators, this is a preventable error. This should never happen under your watch. And if it does, we are not reimbursing you a single dime for the cost of treating that infection.
The financial penalty for the hospital is severe, but the clinical reality for the patient is a matter of life or death. If a CUTI is missed and progresses to urosepsis.
Meaning the bacterial infection has broken out of the urinary tract and is now actively multiplying in the bloodstream.
Right, the mortality rate is staggering. We're talking about a 25 to 60% mortality rate following catheterization-induced urosepsis.
That is why nursing management of these lines is policed so aggressively on the floor. So knowing all of this, what is the nursing student's role?
Your role is deeply rooted in evidence-based practice and strict, uncompromising prevention.
Let's tackle a question patients will definitely ask you. What about cranberry juice? We hear it all the time. I have a catheter. Should I drink cranberry juice to prevent an infection?
It's one of the most persistent pieces of medical lore, but we actually have robust data on it now. A major meta-analysis found that taking daily cranberry capsules or drinking pure cranberry juice does effectively reduce the rate of recurrent UTIs.
But how? Is it killing the bacteria? Because I always thought it was about making the urine more acidic.
That's a common misconception, that it works via acidification. The actual mechanism of action relies on compounds in the cranberries called proanthocyanidins.
Proanthocyanidins.
Yes, these compounds physically interfere with the bacteria's fimbriae, the tiny hair-like appendages they use to cling to surfaces. It essentially prevents the bacteria from adhering to the epithelial cells of the bladder wall.
And if they can't stick, they just get flushed out with the next void.
Precisely. However, and this is a massive caveat for nursing practice, if the patient already has an active symptomatic infection, cranberry products are useless for treatment.
Antibiotics are vastly superior and absolutely necessary for an active infection, despite their potential adverse effects.
Cranberry is strictly for prevention, not a cure.
That's a great distinction to make during patient education. But your primary prevention tool, as the nurse at the bedside, isn't juice, it's your unit's catheter protocol. The first rule is using the absolute smallest catheter size mathematically possible for that specific patient to minimize urethral microtrauma.
You also have to use proper securement devices, like a stat lock attached to the patient's thigh.
Why is the securement device so critical?
Think about the physics of a loose tube. If the catheter isn't secured, every time the patient shifts in bed or moves their leg, that tube slides back and forth in the urethra.
Ouch!
That friction causes microscopic internal abrasions, creating raw tissue that is incredibly susceptible to infection. Furthermore, that sliding motion physically drags bacteria from the outside environment directly into the meatus. Securement is non-negotiable.
You also have to maintain a strictly closed drainage system. You never break the seal between the catheter and the drainage bag to get a urine sample unless it's an absolute emergency.
And you always use the designated needless aspiration port after scrubbing it with alcohol.
You avoid routine irrigation because pushing fluid up into the bladder just churns up bacteria and forces it upward. But the most important nursing intervention, the one that requires you to actively advocate for your patient, is asking the physician during every single daily round.
Does this patient still meet the criteria for this catheter?
Yes. Advocacy is your most powerful tool. The absolute best way to prevent a CAUTI is to get the catheter out as soon as physiologically possible.
Every shift, you must question its necessity.
Get it out ASAP. Make that your clinical mantra. Okay, let's shift gears from infections to something that causes an immense amount of silent suffering. We're talking about voiding dysfunction and incontinence.
Urinary incontinence affects more than 25 million adults in the United States alone.
And it impacts women twice as often as men. But here is the real tragedy of those numbers. They are likely a massive underestimate.
Vastly underreported. Patients are simply too ashamed or embarrassed to bring it up with their healthcare providers. They silently buy absorbent pads at the pharmacy. They map out public restrooms before they leave the house.
They slowly let their world shrink.
It is a profound quality of life issue. And as nurses, we have to be incredibly proactive in asking about it during assessments because patients rarely volunteer the information.
We also need to be very clear in our patient education about a pervasive myth. Incontinence is not a normal, inevitable consequence of aging.
No, it is not.
Wait, really? Because I feel like society just accepts that as you get older, you leak.
It is a deeply ingrained societal myth. Now, are there age-related changes that make incontinence more likely? Absolutely.
Yeah.
As we age, bladder muscle tone decreases, the overall capacity of the bladder shrinks, and the physical structural support in the pelvis weakens.
So these are predisposing factors.
Right. But they do not make incontinence a guaranteed destiny. If a nurse or a provider accepts incontinence as just a normal part of getting older, they will fail to investigate the underlying cause, and they will fail to treat it.
And to treat it effectively, you have to realize that incontinence isn't just one disease. We have to categorize the chaos. There are several distinct types, and each requires a completely different nursing intervention.
Let's run through these types and put a hypothetical patient face to each one, because this is heavy on exams.
First up, stress incontinence. Who is our typical patient here, and what is mechanically failing?
Your classic patient for stress incontinence is often a woman who has had multiple vaginal childbirths, or perhaps a man who has recently undergone a radical prostatectomy.
Okay, so what's happening internally?
In this scenario, the urinary sphincter and the urethra itself are perfectly intact and functioning normally. The failure lies in the structural support surrounding them. The pelvic floor ligaments and musculature have been stretched, damaged, or weakened.
So the pipe is fine, but the scaffolding holding the pipe is falling apart.
Exactly. Because the scaffolding is bent, it cannot withstand sudden spikes in pressure. When the patient coughs, sneezes, blasts heartily, or lifts a heavy box, the intra-abdominal pressure spikes violently,
And that pressure physically overpowers the weakened sphincter mechanism.
forcing a small spurt of urine to leak out. It's entirely mechanically driven by stress on the abdomen.
Contrast that with urge incontinence. This sounds exactly like what the name implies.
It is. With urge incontinence, the structural support might be completely fine. The issue here is neurological or muscular hyperreactivity. The patient feels a sudden, intense, overwhelming urge to void, and they physically cannot suppress it long enough to reach a bathroom.
What's causing that sudden urge? Is the bladder actually full?
Often, it isn't full at all. The underlying pathophysiology is an uninhibited contraction of the detrusor muscle. The bladder muscle simply spasms and starts squeezing aggressively on its own, sending a massive urgency signal to the brain, regardless of the actual volume of urine present.
Next, we have functional incontinence. And honestly, this one breaks my heart a little bit when you see it in clinicals because the urinary system itself isn't broken at all.
That is the tragedy of functional incontinence. The
Yeah.
bladder, the sphincter, the nerves, the pelvic floor, everything anatomically related to urination works perfectly.
The incontinence occurs because a severe physical or cognitive barrier prevents the patient from accessing the toilet in time.
Correct. So we're talking about a patient with advanced Alzheimer's disease who literally cannot remember where the bathroom is located in their own house.
Or a patient with severe, crippling rheumatoid arthritis in their hands who makes it to the bathroom, but physically cannot unbutton their pants or pull down their zipper fast enough.
Precisely. The nursing intervention here has absolutely nothing to do with the bladder. It is about environmental modification. Clear pathways to the bathroom, Velcro clothing instead of buttons, or scheduled toileting assistance.
And we must not overlook iatrogenic incontinence. The prefix iatro, meaning medicine or physician. This incontinence is medically induced. It's an accidental side effect of something we're doing to the patient.
It is surprisingly common, and it's a phenomenal catch for an observant nurse. The classic example involves pharmacology. Imagine a patient who is prescribed an alpha-adrenergic blocker to manage their hypertension.
Okay, those alpha receptors are distributed throughout the vascular system, but they're also heavily concentrated in the bladder neck, where they're responsible for maintaining the resting closing pressure.
Right, so the medication successfully targets the blood vessels to lower the blood pressure, but it accidentally targets the bladder neck too, relaxing it to the point where the patient starts leaking.
The medication relaxes the sphincter tone, inducing incontinence. The vital diagnostic clue here is temporal. The incontinence began shortly after the new medication was introduced.
And if the provider stops or changes the medication, the incontinence completely resolves.
Oh, that is such a great moment for a nurse doing a medication reconciliation. Imagine noticing that pattern. Hey, doc, I was looking through the chart, and the patient's sudden incontinence directly correlates with the initiation of this alpha blocker.
You look like an absolute rock star when you catch that, and you save the patient from unnecessary urological testing.
Lastly, we have overflow incontinence.
Overflow incontinence occurs when the bladder is chronically, massively overdistended. It's essentially overflowing like a bathtub left running with a blocked drain.
The volume and pressure inside the bladder becomes so incredibly high that urine just continuously, passively leaks out past the sphincter.
This is most commonly caused by physical obstruction blocking the outflow, like severe benign prostatic hyperplasia in men, or a neurological issue where the detrusor muscle is totally flaccid and fails to squeeze the urine out, allowing it to pool endlessly.
And of course, in the real world, patients don't always fit perfectly into one box. You can have mixed incontinence, which is usually a combination of stress and urge incontinence happening simultaneously.
Now, once you, the nurse, have investigated and identified the specific type of incontinence, the management phase begins.
Here's where it gets really interesting for nursing students, because the first-line treatments for these non-neurologic types of incontinence aren't complex surgeries or heavy medications.
No, there are behavioral therapies.
And guess who initiates, teaches, and drives behavioral therapy? You do, the nurse. You don't need a surgical suite to cure this. You need excellent communication and patient education skills. Let's talk about fluid management because patients always get this backwards.
It is entirely counterintuitive to the patient. Their logical thought process is, I am leaking urine, therefore I have too much fluid, I should stop drinking water.
But restricting fluids is a massive, highly detrimental mistake. Why? Wouldn't less water mean less urine to leak?
It means less volume of urine, but it drastically alters the composition of the urine. When a patient restricts their water intake, their kidneys still have to excrete the body's daily metabolic waste.
So that waste gets packed into a tiny amount of water.
Yes. The urine becomes highly concentrated, dark, and highly acidic. That concentrated acidic urine acts as a severe chemical irritant to the delicate mucosal lining of the bladder.
It's essentially burning the inside of the bladder.
Exactly. And how does the bladder muscle react to being chemically irritated? It spasms. That irritation triggers the uninhibited detrusor contractions we talked about with urge incontinence.
So by restricting water, the patient is actively causing the bladder spasms that lead directly to severe urgency and frequency.
That is a brilliant physiological explanation that you can easily explain to your patients.
So your nursing intervention is actually to encourage fluid intake, ensuring they're getting an adequate daily volume of roughly 1,500 to 1,600 milliliters consumed in small, steady increments throughout the day rather than chugging it all at night.
And of course, they must avoid known dietary bladder irritants.
Right.
No caffeine, no alcohol, and as we discussed with the JAG layer, absolutely no artificial sweeteners.
Next up in your nursing toolkit is standardized voiding. This isn't just telling them to go to the bathroom more often. There are highly specific, structured strategies you can implement.
Yes, and the strategy depends entirely on the patient's cognitive and physical ability. Let's delineate them. Timed voiding is the most basic. The nurse instructs the patient to void strictly by the clock, for example, every 2 hours on the dot, regardless of whether they actually feel the urge to go.
The goal here is purely mechanical. Keep the volume in the bladder constantly low so it never reaches the threshold where it would leak.
Then you have prompted voiding, which sounds similar but has a different driver.
Prompted voiding relies entirely on a caregiver or the nursing staff. This is used for cognitively impaired patients.
Right. The staff approaches the patient on a schedule, asks if they are wet or dry, prompts them to use the toilet, and physically assists them. It marries the timed schedule with active physical assistance.
Then there is habit retraining. This requires some detective work. You have the patient keep a voiding diary for a few days to figure out when their natural voiding accidents usually happen, and then you proactively schedule their bathroom trips slightly before those predicted times.
But my absolute favorite behavioral intervention, because it sounds like a literal workout routine, is the bladder drill.
The bladder drill is a highly effective therapy for patients struggling specifically with urge incontinence or an overactive bladder. It's essentially physical therapy for the detrusor muscle.
You start the patient on a strict, comfortably short-time schedule, say voiding every 1 hour. Once they master that 1-hour interval without any leakage or severe urgency, you deliberately stretch the interval. You add 15 or 30 minutes to the schedule.
So now they have to hold it for 1 hour and 15 minutes. You're forcing the bladder muscle to adapt to holding slightly more volume, retraining the neurological tolerance over weeks and months.
Exactly. It requires immense patience and compliance from the patient, but the clinical outcomes are phenomenal. Another absolute cornerstone of behavioral therapy, one everyone has heard of but few understand, is pelvic muscle exercises, widely known as Kegel exercises.
Right, Kegels. Every pregnancy magazine talks about them. But the clinical reality is that just handing a patient a printed pamphlet on Kegels as they walk out the door is almost entirely useless, isn't it?
It's clinically ineffective. The problem is proprioception, the patient's awareness of their own body. The pelvic floor muscles are internal and difficult to isolate consciously.
When you tell a patient to squeeze their pelvic floor, the vast majority of people will inadvertently squeeze their abdominal muscles, bear down, or just clench their gluteal muscles.
None of which helps the urinary sphincter. In fact, bearing down increases intra-abdominal pressure and can make stress incontinence worse.
So how do we teach them to find the right muscles?
To be truly effective, teaching Kegels often requires clinical biofeedback. We use vaginal or rectal electromyography sensors, or manometry, to provide the patient with a visual or auditory signal when they physically contract the correct muscle group.
We give them real-time data so their brain can map the neural pathway to that specific muscle.
Once they finally find the right muscle, the exercise prescription is intense. It is not a casual thing. They need to sustain a hard contraction for 5 to 10 seconds, followed by a full 10-second rest to prevent muscle fatigue, and repeat this cycle for 10 to 30 repetitions.
And they must do this entire set 2 to 3 times every single day.
It really is a highly targeted, intense gym routine for the pelvic floor, and it takes time. You have to tell them they won't see results overnight. It takes at least 6 weeks of daily dedication before the muscle hypertrophy provides real improvement.
Now, if behavioral therapies and Kegels don't cut it, we do have medical and surgical backups. For urge incontinence, doctors might prescribe anticholinergic medications.
These drugs block the parasympathetic nerve impulses that cause the bladder to contract, effectively calming down those uninhibited detrusor spasms.
But for stress incontinence, where the physical structure is weak, there are some wild surgical options like periurethral collagen bulking.
Bulking agents are a fantastic, minimally invasive option. It's typically a quick outpatient procedure. The surgeon uses a cystoscope to inject small amounts of artificial collagen, or sometimes synthetic compounds, directly into the submucosal tissue of the urethral walls.
What does that actually do? Does it make the tissue stronger?
It doesn't make the muscle stronger. It physically thickens the walls of the pipe. By bulking up the tissue lining, it artificially narrows the urethral lumen and increases the resting closing pressure.
It provides the physical resistance that the weakened sphincter can no longer provide.
The caveat is that it's semi-permanent. The body's immune system slowly breaks down and absorbs the collagen over 12 to 24 months, so the patient will eventually need repeated injections, but it allows them to avoid the risks of major pelvic surgery.
But for severe cases, particularly in men who have suffered profound sphincter damage following a radical prostatectomy for cancer, there is a literal cyborg option, the artificial urinary sphincter.
It is a remarkable piece of biomedical engineering. When the natural sphincter is irreparably destroyed, a surgeon can implant an artificial one. The device has three parts. First, the surgeon wraps an inflatable fluid-filled silicone cuff completely around the outside of the urethra.
This cuff is connected via hidden tubing to a small pressure-regulating reservoir implanted in the abdomen and to a small control pump that is surgically placed directly inside the scrotum. So how does the patient actually pee?
In its resting state, the cuff stays inflated, clamping the urethra completely shut to maintain perfect continence. When the patient feels the urge to void, they reach down and physically squeeze the pump located inside their scrotum.
Squeezing the pump actively transfers the fluid out of the cuff and up into the abdominal reservoir. This deflates the cuff around the urethra, opening the pipe and allowing urine to flow naturally.
That is incredible, and they don't have to pump it back up.
No, the system is designed with a delayed resistor valve. After a few minutes, the fluid slowly and automatically flows back from the reservoir, reinflating the cuff to stop the flow again.
It completely restores their dignity and their continence.
It gives them their life back. Medical engineering is astounding.
Hmm.
But before we leave the topic of incontinence, we have to touch on a major, unglamorous, but critical nursing responsibility highlighted in the research text. Incontinence-associated dermatitis, or IAD.
We aren't talking about the bladder anymore. We're talking about the skin.
The skin is profoundly vulnerable here. When a patient is bedbound and incontinent in a hospital, their perineal skin is constantly subjected to a highly destructive environment. It isn't just moisture. Urine contains urea, which bacteria rapidly convert into harsh ammonia.
Feces contain digestive enzymes. This combination alters the skin's acidic mantle, macerates the epidermis, and causes rapid, painful skin breakdown.
And here is the clinical trap for nursing students. You absolutely must be able to visually distinguish between IAD and a deep tissue pressure injury, often called a bed sore.
They require totally different treatments, and confusing them is a major documentation error. A critical distinction. IAD is a top-down chemical injury. Visually, it presents as superficial, raw, bright red, inflamed skin that is often widespread and diffuse across the perineum, buttocks, and inner thighs, anywhere the liquid touches.
A pressure injury, conversely, is a bottom-up ischemic injury. It is localized strictly over a bony prominence, like the sacrum or the coccygus, caused by physical pressure cutting off blood flow to the deep tissue, eventually causing a localized ulcer to open up.
A study highlighted in the reading showed that while ICU nurses have excellent attitudes about preventing IAD, there is a serious lack of standardized knowledge on how to accurately assess and treat it. Your experience, your vigilance in applying barrier creams, and your diligence in timely brief changes dictate whether that patient develops a painful, infected wound.
You are the barrier between their skin and chemical burns. Okay, let's shift our focus entirely. We've talked about the inability to hold urine. Now let's explore the inability to release it. We are looking at urinary retention and the incredibly complex neurogenic bladder.
Retention is a fundamental failure of the bladder's emptying mechanism. By definition, it means the bladder cannot empty itself completely during voiding. We measure this via post-void residual, or PVR.
In a healthy adult, the residual urine left pooling in the bladder immediately after the old void should be less than 50 milliliters, basically empty. What about in the older population we were discussing earlier? Is it the same?
We allow a slightly higher margin in geriatrics. Because of normal age-related decreases in detrusor muscle contractility, the muscle just doesn't squeeze as hard anymore, we might accept a post-void residual of up to 50 to 100 milliliters in adults over 60.
But anything significantly above that threshold indicates pathological retention. And the causes of retention are lurking everywhere on a med-surg floor. It's not just one disease.
You'll see it constantly post-operatively, especially in the PCU after general anesthesia or a spinal epidural.
The anesthesia totally suppresses the neurological urge to void, and the sphincter stays clamped shut even though the IV fluids are filling the bladder rapidly.
You'll see it in diabetic patients whose chronically high blood sugar has caused peripheral autonomic neuropathy, destroying the nerves that tell the bladder to squeeze.
You'll see it in men with severe BPH, where the enlarged prostate literally strangles the urethra shut like a kinked garden hose.
Of course, you'll see it in trauma patients with spinal cord injuries. Which brings us to a massive, highly testable topic, the neurogenic bladder.
The neurogenic bladder is complex because it is entirely dependent on where the neurological wiring is damaged. The bladder itself is physically healthy. The communication network is destroyed. Generally, it presents in two drastically different forms, spastic and flaccid. Let's break those down. What is the difference anatomically between a spastic bladder and a flaccid bladder?
It all revolves around the voiding reflex arc in the spinal cord. Let's start with the spastic or reflex bladder. This occurs when a patient suffers an upper motor neuron lesion, meaning the physical damage to the spinal cord, like a cervical or high thoracic spinal cord injury, occurs above the level of the voiding reflex arc.
So the local loop in the lower spine is still intact, but the main cable to the brain is cut.
Exactly. The local reflex arc works, but the connection to the cerebral cortex is severed. As a result, the brain receives no sensory information from the bladder, so the patient loses all conscious sensation of bladder fullness.
Furthermore, the brain can no longer send inhibitory signals to control the bladder.
So the bladder fills up slowly until the local stretch receptors in the wall are triggered. Once triggered, the local reflex arc fires independently, and the bladder reflexively violently contracts and empties on its own, with absolutely no warning or control from the patient.
It's like a balloon that randomly pops itself whenever it gets moderately full. Contrast that with a flaccid bladder.
A flaccid bladder is caused by a lower motor neuron lesion. This is often the result of trauma to the lower spine or advanced peripheral neuropathies like we see in severe diabetes. In this scenario, the damage is at or below the reflex arc. The reflex arc itself is completely destroyed.
So there is no local loop and no brain connection.
Correct.
Yeah.
The detrusor muscle is completely paralyzed. It never receives a signal to contract. So what happens? The bladder just acts like an ever-expanding passive reservoir. It fills and stretches and distends massively. It never squeezes.
Eventually, the hydrostatic pressure inside the bladder overcomes the sphincter pressure, and urine just passively constantly overflows. And because the sensory nerves are destroyed along with the motor nerves, the patient feels absolutely no pain or discomfort, even if their bladder is holding a literal liter of urine.
Which is terrifying from a clinical standpoint. Without the sensation of pain to warn them, the patient is entirely unaware of the danger. All that stagnant, retained urine is a massive breeding ground for severe bacterial infection.
Worse, the extreme pressure inside that distended bladder will cause backward pressure up the ureters, that reflux we discussed, which will permanently crush and destroy the microscopic nephrons in the kidneys. So, if the patient can't tell you they are retaining, what is the nursing toolkit for identifying it? Because you have to proactively suspect it.
Assessment relies on physical signs and vital signs. If a patient is inexplicably restless or diaphoretic, look at their abdomen. Do they have a visibly swollen, rounded mound just above the pubic bone?
If you tap, percuss that suprapubic area, do you hear a hollow drum-like sound of the bowel? Or do you hear a solid, dull thud indicative of a fluid-filled mass? Furthermore, review their intake and output chart. If they are voiding 20 to 30 milliliters very frequently, say every 30 minutes, that is a massive red flag.
Wait, if they are voiding frequently, doesn't that mean they are emptying?
No, it is the exact opposite. That is overflow incontinence masking as frequency. They are actively emptying the bladder. The bladder is completely full, and they were just spilling the top 20 milliliters over the edge every time the pressure spikes.
That is such a vital distinction to make. Frequency does not equal emptying. Your absolute best friend on the unit in this scenario is the bedside bladder scanner. It's a portable, non-invasive ultrasound device. You put some gel on the lower abdomen, point the wand at the pelvis, and the machine calculates exactly how many milliliters of urine are hiding in there. If you scan them and see 600 milliliters, you know you have a problem.
And if they are retaining, your first interventions should always be non-invasive before you reach for a catheter. Provide them with strict privacy, as psychological anxiety can clamp the sphincter shut. Provide a warm compress to the perineum to help relax the musculature. And try what we call trigger techniques.
Trigger techniques are fascinating because they sound almost like old wives' tales,
Mm-hmm.
but they work on neurological reflexes. You can run the water faucet so they hear the sound of flowing water.
You can lightly stroke the inner thighs or tap rhythmically on the suprapubic area to try and stimulate the reflex arc. You can have them dip their hands in a basin of warm water. And for a flaccid bladder, you teach the patient a technique called double voiding.
Double voiding is a great mechanical strategy. You instruct the patient to void as much as they can, remain seated on the toilet, and completely relax for 2 to 3 minutes, and then actively try to void again, perhaps using the Valsalva maneuver, bearing down, to manually squeeze out the remaining residual urine.
But if all those behavioral and non-invasive techniques fail and the bladder is expanding dangerously, we have to drain it mechanically. We have to catheterize. And what's fascinating here is the stark, almost unbelievable shift in nursing protocol, depending on whether the patient is in the hospital or managing their chronic retention at home.
This is a concept that frequently causes cognitive dissonance for nursing students. Let's establish the hospital standard first. In the acute care setting, inserting a straight or Philly catheter is a strictly sterile procedure. We mandate sterile gloves, sterile drapes, sterile betadine prep, and single-use sterile catheters.
The rationale is that the hospital environment is teeming with highly virulent, antibiotic-resistant nosocomial pathogens, superbugs. We must maintain absolute sterility to prevent introducing these superbugs into the urinary tract. That makes perfect sense. But for patients with chronic retention, like a young person with a spinal cord injury who goes home and lives independently, they are taught intermittent self-catheterization, and at home they use a clean technique, not a sterile one.
That is correct. They use a clean technique.
That blows students' minds. Wait, they don't use sterile gloves. They don't use single-use packaged catheters. They just use soap and tap water. How does that not lead to constant raging infections?
It comes down to the brilliance of the human immune system and the concept of localized environmental flora. At home, the patient is only exposed to their own normal household bacteria, the microbes that already live on their skin, in their bathroom, and on their hands.
Their immune system is intimately familiar with these specific microbes and has a robust, localized defense ready for them. The immune system tolerates the familiar. Therefore, sterile technique is unnecessary and cost prohibitive.
So they literally just wash their hands, take a reusable plastic catheter, wash it with standard antibacterial liquid soap, rinse it with warm tap water from the sink, let it air dry on a clean paper towel, and keep it in a plastic sandwich bag.
Exactly. That is the standard of care for home management. And the physical mechanics of teaching a patient to self-catheterize are highly specific and highly testable. The approach varies drastically by anatomy. For a female patient, teaching focuses on positioning and visualization. You teach her to assume a Fowler position or sit on the toilet with knees apart.
She uses a small mirror propped between her legs to visually locate the urethral meatus, which can be difficult to find. She cleanses the area, lubricates the catheter, and inserts it about 3 inches in a downward and backward trajectory.
For a male patient, it is a bit more anatomically complex because the male urethra is significantly longer and has a distinct natural curve around the prostate gland. Because of that curve, technique is paramount to avoid injury. He assumes a sitting or semi-Fowler position. If he is uncircumcised, he absolutely must retract the foreskin first. He then grasps the penis firmly and holds it at a strict 90-degree right angle straight up and out from the body.
Why the right angle? That seems very specific.
It is entirely mechanical. By holding it at a right angle, he physically straightens out the natural S-curve of the urethra. It aligns the urethral pathway so the rigid catheter can pass smoothly without catching or digging into the tissue near the prostate. Once aligned, he inserts the lubricated catheter a full 6 to 10 inches until urine begins to flow steadily.
Mastering this technique gives these patients incredible independence, prevents kidney destruction, and drastically reduces their risk of infection compared to being tethered to a permanent indwelling Foley bag.
That right angle trick is pure gold for your clinicals. Don't force a catheter, straighten the anatomy. Okay, moving on to a topic that makes everyone wince just thinking about it. We're talking about stones. Urolithiasis, which refers to stones forming anywhere in the urinary tract, and nephrolithiasis, which specifically refers to stones forming inside the kidney itself. We all know kidney stones are synonymous with agonizing pain, but let's dive into the pathology. How does a hard rock form inside a liquid environment in the body?
It is a process of supersaturation. Stones form when the urine becomes supersaturated with specific crystalline minerals, usually calcium or uric acid. The concentration of these minerals becomes so high that the liquid urine can no longer dissolve them. They precipitate out of the liquid phase and crystallize together layer by layer, forming a solid mass. Historically, this affects men roughly twice as often as women, though dietary shifts are rapidly closing that statistical gap.
And we don't just lump all stones together. We categorize stones by exactly what minerals they are made of because the chemical composition completely dictates our medical and dietary treatment. The vast majority, up to 80% of stones, are calcium stones, specifically calcium oxalate or calcium phosphate. These occur when there is an excess of calcium circulating in the blood or being dumped into the urine. This can be driven by a hyperactive parathyroid gland or, surprisingly, by periods of prolonged immobility.
Wait, how does lying in bed cause a kidney stone?
When a patient is immobile for weeks, say after a severe fracture, the lack of weight-bearing stress on the bones causes them to slowly demineralize. The calcium leaches out of the bone matrix, enters the bloodstream, and has to be filtered out by the kidneys, creating a massive spike in urinary calcium, which leads to stones. That's a fascinating systemic connection. Bone health directly impacting kidney health. Then you have uric acid stones.
Uric acid stones account for about 5 to 10% of cases. We see these primarily in men, particularly those with a clinical history of gout or patients undergoing chemotherapy for certain myeloproliferative blood disorders, which causes massive cellular breakdown and uric acid release.
And then there are struvite stones. From what I've read, these are absolute nightmares. They don't just form from a bad diet, they form from an infection, right?
Struvite stones are a unique and dangerous pathology. They form almost exclusively in abnormally alkaline ammonia-rich urine. And the only thing that makes urine highly alkaline and full of ammonia is the presence of urea-splitting bacteria, specifically organisms like Proteus, Klebsiella, or Pseudomonas.
So the bacteria are actually changing the chemical environment of the kidney to build themselves a house.
That is a brilliant way to phrase it. Struvite stones are essentially infected boulders growing rapidly inside the renal pelvis. They can grow so large they fill the entire cavity, forming what we call a staghorn calculus. They are incredibly serious because the stone itself harbors the living bacteria deep within its porous structure, protecting them from circulating antibiotics. You cannot eradicate the infection until you physically remove the stone, and the stone will keep growing as long as the infection is there. It is a vicious, destructive cycle.
Regardless of the chemical type, the patient experience is almost universally defined by one thing: overwhelming pain. When a stone breaks loose from the kidney and lodges in the narrow, muscular tube of the ureter, it causes a severe ureteral obstruction. The kidney continues making urine, but the urine has nowhere to go.
The body responds to the obstruction aggressively. The ureter tries to physically force the stone through by going into massive spastic hyperperistalsis. This results in acute, excruciating, wave-like colicky pain that radiates from the deep flank down around the abdomen into the thigh and right down into the genitalia. The patient is often writhing in agony, violently nauseous, and desperate for relief.
And this intense pain isn't just mechanical stretching. It is directly mediated by a specific chemical messenger called prostaglandin E.
Prostaglandin E is the primary villain in the story of renal colic. The local tissue trauma from the stone triggers a massive release of prostaglandin E. This chemical does two devastating things simultaneously. First, it directly increases ureteral contractility, causing those violent, crushing muscle spasms. Second, it drastically increases renal blood flow to the affected kidney.
Why is increased blood flow bad? Wouldn't you want more blood to heal the area?
Not when the pipe is blocked. Increased blood flow means the kidney produces even more urine, which can't escape. This rapidly swells the kidney capsule and drastically, dangerously increases the hydrostatic pressure behind the stone, amplifying the pain exponentially.
So, as a bedside nurse, your absolute top priority is pain relief. You cannot educate a patient who is writhing in agony. You will likely administer 5E opioids to blunt the severe pain perception and prevent the patient from going into shock or syncope from the sheer physiological stress. But the real pharmacological heroes in this specific scenario are IV NSAIDs, non-steroidal anti-inflammatory drugs like ketorolac.
The preference for NSAIDs over opioids here is a masterclass in targeted pharmacology. While opioids just mask the brain's perception of pain, NSAIDs work directly on the pathophysiology. NSAIDs specifically inhibit the synthesis of prostaglandin E.
So, by giving an IV NSAID, you are turning off the chemical switch. You stop the violent spasms, you reduce the inflammatory swelling of the ureteral wall, and you decrease that localized blood flow, which lowers the pressure behind the stone. You are literally widening the pathway, making it physically easier for the stone to pass. It is targeted, physiological relief rather than just an analgesic Band-Aid.
It is brilliant pharmacology.
Yeah.
And while you are aggressively managing their pain and pushing IV fluids to help flush the stone, your absolute mandate as a nurse is to strain all of their urine. You place a fine mesh strainer over the toilet or commode, and if they pass what looks like dark blood clots, your job isn't done. You put on your gloves and you physically crush those clots with your fingers to look for the tiny, sharp, granular stones hiding inside. We must capture that stone and send it to the lab to determine its chemical composition.
Which brings us to a massive topic, the dietary management of stones. This is a subject absolutely riddled with outdated misconceptions that you will have to unteach your patients. So what does this all mean for patient diets once they go home? Let's take calcium stones. For decades, the standard medical advice given to patients with calcium stones was to stop eating dairy, stop drinking milk, cut out calcium completely.
It was standard advice, and it was completely wrong. The modern evidence-based research now is absolutely clear on this, and it is a vital patient education point. Restricting dietary calcium does not prevent stones for the vast majority of people. In fact, severe calcium restriction is dangerous. It leads directly to a negative calcium balance and early-onset osteoporosis, particularly devastating in women.
Oh.
You do not tell these patients to restrict their calcium intake.
That completely flips the traditional advice on its head. If calcium isn't the enemy, what is?
Sodium. You aggressively restrict sodium. You educate the patient to limit their sodium intake to 3 to 4 grams a day, maximum. The physiological reason is found deep in the renal tubules. In the kidneys, sodium and calcium share a cellular transport mechanism. They directly compete for renal reabsorption back into the bloodstream.
Oh, this is a phenomenal physiological connection. Walk us through that competition.
If a patient eats a highly processed, salty diet, there's a massive amount of sodium entering the gill filtrate. The kidneys are forced to focus all their transport energy on processing that overwhelming sodium load. Because they are so busy handling the sodium, they ignore the calcium. The calcium fails to get reabsorbed and is allowed to spill out heavily into the urine. Therefore, high sodium in the diet directly equals high calcium in the urine, and high calcium in the urine equals calcium stones. You don't restrict the calcium on their plate, you restrict the salt that forces the calcium into the urine.
That is the exact kind of why explanation that will make you a brilliant nurse educator. So limit the salt. You also want to look at oxalates if the lab confirms they form calcium and oxalate stones. You tell them to go easy on high oxalate foods, things like raw spinach, Swiss chard, dark chocolate, and peanuts. If the lab shows they form uric acid stones, they need a low purine diet, limiting rich foods like shellfish, anchovies, mushrooms, and organ meats. And for every single stone former, regardless of type, you push fluids. Water is the universal solvent. Dilution is the ultimate solution to pollution.
Indeed. But what if dietary changes in IV fluids aren't enough? If the stone is simply too large to pass naturally, generally anything over a centimeter in diameter, the urologist has to go in and physically break it up. The most common non-invasive procedure you will see is ESWL, extracorporeal shockwave lithotripsy.
Extracorporeal meaning outside the body. This is a wild procedure. The patient isn't cut open at all. They are positioned precisely on a special table, sometimes submerged in a water bath or against a fluid-filled cushion. A machine then fires high-energy electromagnetic or acoustic shock waves from outside the body, directed precisely through their skin and soft tissues, focusing the energy waves exactly on the stone inside the kidney.
The physics of it are remarkable. The waves pass harmlessly through the fluid-rich soft tissues of the body without causing damage. But when those concentrated energy waves hit the dense, rigid structure of the stone, the sheer force of the impact shatters the rock into tiny, passable fragments, effectively turning a boulder into a pile of sand.
But the nursing care post-ESWL is intense and requires massive patient education. The procedure might be non-invasive, but the aftermath isn't. You have to educate the patient that the stone isn't gone, it's just broken. They're going to be peeing out sharp microscopic grains of sand for weeks. You still have to send them home with a strainer, and they will absolutely have hematuria, gross blood in the urine, for 4 to 5 days post-procedure.
And you must reassure them that this hematuria is completely expected. Their kidney was just subjected to thousands of localized shockwaves. Some capillary bleeding is inevitable. If ESWL fails, or the stone is too complex, surgeons must escalate to invasive measures. They might perform a ureteroscopy, threading a tiny fiber optic scope and a laser directly up the urethra, through the bladder and up the ureter to blast the stone at point-blank range. Or for massive stones, a percutaneous nephrolithotomy, where the surgeon literally punches a small hole straight through the patient's back, directly into the kidney to pull the stone pieces out with a tiny basket.
Urology is definitely not for the faint of heart. Speaking of things getting stuck and causing internal damage, what happens when the damage to the genitourinary system comes from the outside? That is a perfect segue into trauma and tumors. We need to discuss how to protect and treat a critically injured GU tract in an emergency setting.
Genitourinary trauma usually results from significant physical force. Blunt trauma accounts for roughly 85% of these injuries. Visualize a severe car crash where the driver is violently thrown forward, driving their lower abdomen directly into the steering column, or a severe crush injury to the pelvis in an industrial accident. Penetrating trauma, like gunshot wounds or deep stabbings, makes up the remaining 15%. But the most critical, immediate assessment a trauma nurse must make in the emergency department involves suspected trauma to the lower urethra.
Everyone listening, pay extremely close attention here because this is a classic, highly testable emergency scenario, and messing it up has catastrophic consequences for the patient. If a trauma patient is rolled into your ER with a suspected pelvic fracture or severe blunt lower abdominal trauma, you are meticulously looking for the classic triad of urethral trauma.
The triad is definitive. 1, is there visible blood at the urinary meatus? 2, does the person have the absolute inability to void, even if their bladder is completely full? 3, is there a visibly or palpably distended bladder? If you observe those 3 specific signs together, a massive clinical alarm should be blaring in your head. The urethra has likely been compromised.
I've seen the term classic triad thrown around. If I'm that ER nurse and I see the blood at the meatus, what is my immediate clinical mandate? Do I try to put a Foley in to drain that distended bladder?
You do absolutely nothing of the sort. The clinical mandate in that exact scenario is an absolute contraindication. You never, ever blindly insert a Foley catheter if you suspect urethral trauma.
Why? Wouldn't draining the bladder relieve the pressure?
The risk of mechanical destruction is too high. If the urethra has sustained a partial tear from the pelvic bone fracturing, the delicate mucosal tissue is hanging by a thread. Pushing a stiff plastic catheter blindly up that damaged pipe can catch the edge of the tear and completely transect it, shearing the urethra entirely in half. You just transformed a surgically repairable injury into a lifelong, devastating nightmare of severe strictures, permanent incontinence, and permanent impotence.
Wow, protect the pipe. Do not place the Foley. So how do we drain the urine if we can't use the normal route?
The urologist must be paged immediately to perform a suprapubic catheterization. They bypass the damaged urethra entirely by making a small incision in the lower abdomen and placing a drainage tube directly through the abdominal wall, straight into the distended bladder. This safely diverts the urine and allows the urethral tear to heal without further mechanical trauma.
That is a phenomenal piece of emergency nursing knowledge. Moving from acute external trauma to slow-growing internal chronic disease, let's talk about bladder cancer. Bladder cancer is a heavy hitter. It causes over 15,000 deaths a year in the U.S. And when we talk about risk factors, people always assume it's related to artificial sweeteners or drinking bad water or chronic kidney infections. But the leading risk factor is much more common.
It is entirely behavioral. Tobacco use. Cigarette smoking is the absolute #1 risk factor for developing bladder cancer, accounting for roughly half of all cases.
Wait, smoking? How does inhaling smoke into your lungs cause cancer in your bladder?
It is about systemic filtration and exposure time. The powerful carcinogens from the cigarette smoke enter the pulmonary bloodstream, circulate through the body, and are inevitably filtered out by the kidneys. These concentrated carcinogens are then dumped into the urine. The urine flows down into the bladder, which, remember, is just a holding tank. Those toxic chemicals sit there, pooling and constantly bathing the delicate urothelium lining in concentrated carcinogens for hours between voiding. Over years, this massive chemical exposure triggers malignant cellular mutations.
That makes terrifying sense. The bladder is literally soaking in the filter toxins. So what is the hallmark symptom that finally brings this patient into the clinic?
The classic hallmark symptom, the one that should immediately trigger a full urological workup, is visible, painless hematuria.
Painless. Why is the lack of pain the scary part?
Because painful hematuria usually points to an acute, benign cause, like a jagged kidney stone scraping the ureter, or a severe UTI causing inflammation.
Yeah.
But if a patient, particularly an older adult with a history of smoking, comes to you and says, "My urine was bright red yesterday, but I feel totally fine, it didn't hurt at all," bladder cancer must be ruled out immediately. A growing tumor bleeding into the bladder cavity doesn't cause acute pain until it grows large enough to obstruct the system or invade deep muscle layers.
If they do catch it early, and it is still a superficial tumor, meaning it's only on the surface lining and hasn't invaded the deep muscle, the treatment involves what I think is one of the most wild, fascinating intersections of infectious disease and oncology in all of modern medicine.
It truly is a biological marvel. We are talking about BCG Live, Bacillus-Calmette-Guerin. It is not a traditional chemical chemotherapy, it is immunotherapy. BCG is literally an attenuated live strain of tuberculosis, specifically Mycobacterium bovis.
Wait, we treat cancer by injecting live tuberculosis into the patient.
Exactly. The urologic surgeon goes in with a scope, scrapes away the visible superficial tumor, and then, as a follow-up treatment over several weeks, we literally inject live tuberculosis bacteria directly into the patient's bladder through a standard urinary catheter.
Why on earth do we do this? Is the tuberculosis eating the cancer?
No, the bacteria don't eat the cancer. We do it to weaponize the patient's own immune system. The mucosal immune system in the bladder is somewhat sluggish. It often ignores superficial cancer cells. By injecting a highly provocative, dangerous pathogen like live tuberculosis, we essentially set off a biological smoke bomb in the room. The local tissue freaks out. It detects the TB and mounts a massive, overwhelming, hyper-aggressive local inflammatory and systemic immune response to fight the infection.
Oh, I see. So all the white blood cells, the macrophages, the killer T cells all rush into the bladder to kill the TB.
Precisely. And in the chaotic crossfire of this massive immune war, those hyperactivated immune cells suddenly recognize and completely eradicate any remaining microscopic cancer cells that were hiding in the lining. The body's immune system does the work. BCG has a significantly higher success rate in preventing tumor recurrence than standard chemical chemotherapy installation.
Harnessing an infectious disease to cure cancer, unbelievable.
Yeah.
But the nursing care for a BCG installation is very specific because we are handling a live pathogen. The patient comes into the clinic, you instill the live bacteria via a temporary catheter, and then you remove or clamp it. The patient has to physically hold that irritating solution inside their bladder for a full 2 hours to ensure maximum contact time with the mucosal walls. After 2 hours, they void, and what do you tell them?
You instruct them to drink copious, massive amounts of fluids immediately. They need to mechanically flush the dead tissue, the inflammatory debris, and the remaining live bacteria completely out of their system. You also must instruct them on strict bathroom hygiene at home, using bleach in the toilet after voiding, because they are shedding live, albeit weakened, tuberculosis bacteria.
But what if the cancer isn't superficial? What if it is deeply invasive and has penetrated the thick muscular wall of the bladder? Superficial smoke bombs like BCG won't work anymore?
If the cancer is deeply invasive, the only curative option left is a radical cystectomy, the complete surgical removal of the entire urinary bladder and often surrounding reproductive organs to ensure clear margins.
And if you remove the bladder, you eliminate the body's storage tank. You must surgically create a completely new way for urine to exit the body. This brings us to our final major topic, rerouting the system. The complex, life-altering reality of urinary diversions.
This is massive, life-altering surgery. We are talking about fundamentally altering a patient's anatomy, their daily routine, and their deeply held body image. There are 3 main types of urinary diversions that nursing students must understand intimately: the ileal conduit, the orthotopic neobladder, and the Indiana pouch.
Let's start with the oldest, structurally simplest, and still the most common diversion, the ileal conduit. How do we build a new exit without a bladder?
In an ileal conduit, the surgeon turns to the gastrointestinal tract for spare parts. They take a 12-centimeter loop of the patient's ileum, a segment of the small intestine. They completely sever this loop from the digestive tract, taking great care to leave its delicate mesenteric blood supply perfectly intact. They then sew the remaining digestive intestine back together, anastomosing it so normal digestion can continue uninterrupted.
So now the surgeon is holding a small, isolated, living tube of intestine that is no longer part of the GI tract.
Correct. The surgeon then takes the 2 ureters that are coming down from the kidneys and surgically implants them into one end of this newly isolated intestinal loop. The other end of the loop is brought directly out through an incision in the abdominal wall, creating a permanent, visible stoma on the patient's belly.
So the path is now urine flows from the kidneys down the ureters into this little piece of intestine and flows right out the stoma on the abdomen. There is no internal storage. There's no sphincter valve. It just drains continuously 24 hours a day, 7 days a week into an external ostomy bag adhered to the skin.
Exactly. And your post-operative nursing management in the acute phase is incredibly intense. Because of all the surgical trauma and swelling at the connection points, surgeons will often place tiny temporary plastic stents up the ureters to keep them propped open. Your absolute critical duty is to monitor that urine output hourly. Hourly without fail. The output must be greater than zero point 0.5 milliliters per kilogram of body weight per hour.
Why is zero point 0.5 milliliters per kilogram per hour the magic number? What happens if it drops below that?
That volume is the absolute minimum threshold required to prove the kidneys are adequately perfused and functioning. If the output drops below that, it signals a massive physiological crisis. It could mean the kidneys are shutting down from surgical shock. Or, mechanically, it could mean there is a physical obstruction, like a blood clot blocking the stents, or a catastrophic leak at the surgical anastomosis where the ureters meet the intestine, meaning urine is spilling freely into the sterile abdominal cavity. Any drop below that threshold is a surgical emergency.
Equally important is your visual assessment of the stoma itself. Let's remember what that stoma is made of. It is living intestinal mucosal tissue. A healthy, well-perfused stoma is beefy red or bright pink, and it should be glistening and moist. If you assess a patient's stoma and it is turning dark purple, dusky brown, or black, what is happening?
That color change indicates acute ischemia and rapid tissue necrosis. The delicate mesenteric blood supply that the surgeon carefully preserved has been compromised. Perhaps it twisted, or a blood clot formed in the artery. The tissue of the stoma is actively dying. That is not a finding you simply chart in the computer and wait for morning rounds. That is an immediate drop-everything surgical emergency requiring the surgeon at the bedside immediately to salvage the tissue.
Now here is a clinical pearl for the ileal conduit regarding patient education, and it has to do with mucus. Imagine you're doing your 2 a.m. rounds and your patient with a brand new ileal conduit calls you in. They look at their clear ostomy bag and it's full of this thick, cloudy, stringy white mucus. Their first instinct is absolute panic. They think they have a massive, raging infection.
It is a terrifying sight for an uneducated patient.
Yep.
But you must calmly explain the biology to them. The new conduit is made of intestinal tissue. What is the primary job of the intestinal lining? It is evolutionarily designed to secrete copious amounts of mucus to help solid foods slide along the digestive tract.
Just because the surgeon moved that piece of intestine to the urinary tract doesn't mean it forgets its old job.
Precisely. The intestinal goblet cells will continue to secrete thick mucus into the urine stream indefinitely. You have to proactively educate them before surgery. You will see a lot of thick mucus in your bag, and that is actually a wonderful sign. It means your new system is alive, healthy, and doing exactly what its cells are programmed to do.
Education prevents panic. But let's be honest, many patients are deeply psychologically devastated by the idea of wearing an external pouch of urine on their abdomen for the rest of their lives. It affects how they dress, how they engage in intimacy, and how they view themselves. For those patients, if they meet very strict medical and anatomical criteria, the surgeon might attempt a much more complex procedure, an orthotopic neobladder.
Ortho meaning correct or natural, topic meaning place.
Yeah.
In this monumental procedure, the surgeon takes a much larger section of the patient's intestine, usually a long segment of ileum. They cut it open, reshape it, and sew it into a spherical pouch, literally constructing a completely new anatomical bladder. They connect the ureters to the top of the sphere, and incredibly, they sew the bottom neck of this new pouch directly to the patient's native remaining urethra.
So there is no stoma on the belly, there is no external plastic bag. The patient will urinate through their natural anatomy. It sounds like an absolute miracle of modern surgery.
It is a surgical marvel, but it comes with a massive physiological catch that completely dictates your nursing care. This new bladder is structurally made of intestine. It does not possess the complex neurological wiring, the stretch receptors, or the autonomic communication network of a true urothelial bladder.
So when it fills up with urine, there are no stretch receptors sending a nerve signal to the brain saying, hey, I'm getting full, time to find a bathroom. The patient feels absolutely nothing.
They feel nothing resembling a normal urge to void. They might feel vague abdominal pressure, but that is all. If the patient simply waits for a normal urge, the neobladder will silently overfill, stretch out dangerously, and eventually either rupture the suture lines or cause massive destructive reflux back up into the kidneys.
Therefore, new bladder retraining is a monumental nurse-driven task. The patient must be meticulously taught to void on a strict, rigid schedule, usually every 2 to 3 hours, day and night, regardless of how they feel. And because the intestine doesn't have a specialized detrusor muscle to autonomously squeeze the urine out, how do they physically empty it?
The patient must learn to manipulate their surrounding musculature. They must use the Valsalva maneuver. They have to sit down, bear down forcefully with their abdominal muscles, and manually squeeze the intestinal pouch empty using external pressure while simultaneously consciously relaxing their external pelvic sphincter. It requires immense dedication and physical coordination. And even with perfect training, because there is no reflex arc, nighttime incontinence during deep sleep is a very common, often permanent reality that these patients must accept.
The third major option is the Indiana pouch. This is essentially a middle ground between the first two. It is a continent internal reservoir. The surgeon builds a large pouch internally out of the ileum and the cecum to hold the urine. They bring a small piece of intestine to the surface as a stoma. But here's the genius part. They surgically create a specialized, narrowed, intussuscepted one-way valve right behind the stoma.
That valve is the key. The urine flows from the kidneys and collects internally inside the pouch, but the surgical valve prevents it from leaking out the stoma. There is no external bag constantly collecting fluid. The stoma can simply be covered with a small bandage.
But the trade-off is intense. Because the urine is trapped inside, the patient must take a clean catheter, lubricate it, and physically slide it directly into their own abdominal stoma past the surgical valve to drain the internal pouch every 4 to 6 hours.
It provides continence and excellent body image without the risk of an external bag. But the strict adherence to the self-catheterization schedule is absolutely non-negotiable. If they forget or decide they are too busy to drain it, the pouch will severely overdistend. This can tear the internal suture lines. More insidiously, because the pouch is made of highly absorptive intestinal mucosa, if the urine sits in there too long, the intestinal wall will actually start actively reabsorbing the toxic metabolic waste products from the urine directly back into the bloodstream, causing severe metabolic acidosis and systemic illness.
The physical mechanics are complex, but the psychosocial care for all of these patients, regardless of the diversion type, is profound. You are dealing with massive traumatic alterations to body image, self-esteem, and sexuality. This is where the wound ostomy continence, or WOC nurse, becomes the most vital person on the care team. Having the WOC nurse consult with the patient preoperatively to mark the ideal stoma site on the abdomen can literally dictate their entire quality of life post-op.
The WOC nurse's assessment is critical. They observe the patient sitting, standing, and bending over. They identify natural skin folds, assess the patient's typical belt line, and locate the rectus abdominis muscle. A poorly placed stoma, one that ends up hidden inside a deep abdominal skin fold or right on the crease of a waistline where clothing rubs it, will constantly break the seal of the ostomy bag. It will leak acidic urine onto the skin every time the patient bends over. That is a physiological disaster causing severe skin breakdown and a psychological disaster causing profound social isolation.
Exactly. The technical, cold mechanics of the surgery are only half the battle. The warm, empathetic nursing care, the meticulous education on how to empty a pouch, and the deep psychological support are what actually allow the patient to survive the trauma and eventually thrive with their new, rewired anatomy.
That is the essence of nursing, translating the medical procedure into a livable human reality.
And that, future nurses, wraps up our incredibly deep dive into the genitourinary system. We have covered a staggering amount of clinical ground today, from realizing that an elderly patient's sudden and terrifying delirium might just be a UTI hiding behind an aging immune system, to fiercely protecting your patients from the CI-UTI crisis by aggressively advocating to get that fully out.
From teaching a stressed incontinent mother how to actually locate and isolate her pelvic floor muscles with biofeedback, to crushing blood clots with your gloved fingers looking for a prostaglandin-inducing struvite stone.
You've seen the absolute critical importance of never blindly catheterizing a trauma patient, and you've walked through the complex, life-altering reality of managing mucus-filled ileal conduits and retraining intestinal near-bladder reflexes. The urinary system is not just plumbing. It requires meticulous, proactive, highly educated nursing care. You are the frontline defense.
You truly are. The impact of an observant nurse in this specialty cannot be overstated. And as we leave you today, I want to offer a final, somewhat philosophical, highly provocative thought to mull over before your next clinical shift, building on what we discussed about the orthotopic neobladder.
A parting thought.
Think about the sheer biological marvel and the inherent cellular conflict of that specific surgery. The human body is remarkably, almost terrifyingly adaptable. When surgeons take a piece of the ileum, tissue that has been evolutionarily designed for millions of years to secrete mucus, aggressively absorb nutrients, and move solid waste via peristalsis, and suddenly force it to act as a static holding tank for highly acidic, completely sterile, toxic urine, a microscopic identity crisis occurs.
An identity crisis at the cellular level.
Precisely. The cells are subjected to an entirely alien environment. Over years and decades of holding toxic urine instead of digesting nutrients, does that intestinal tissue fundamentally change its cellular structure? Does it undergo metaplasia to physically mimic the original urothelial bladder tissue it replaced?
How does the human body negotiate that anatomical real estate swap at a genetic level, abandoning its original programming to survive a new, hostile environment?
It is a profound testament to the adaptability of human biology and the absolute ingenuity of modern surgical intervention. Something to ponder the next time you're standing at the bedside, meticulously checking that hourly urine output.
Thank you for exploring the depths of MedSurg with us. Keep questioning, keep learning, and we will catch you on the next deep dive.